Hi, 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 hi. Good evening. Zooming, zooming. Then on. More than
You will
that.
introduce the speaker, no? Hello,
Yes,
Dr. Amit. You will introduce the speaker, right?
yeah, I will introduce in fact, I will introduce you people and then you all will introduce this speaker. We'll put his uh, a slide and
Yeah.
you can speak on it. Adrian is from
Hmm.
France. So should I'm just sending you his, uh,
Yeah, but
uh,
like Nutan ma'am is there, no?
yeah, Nutan ma'am is there. Yeah, yeah, she will. Hi, Adrian.
Hello.
How are you?
Very fine, thank you. Happy to be here with
Yeah,
you.
yeah. So
Hello,
this is
Dr.
Dr.
Adrian. I'm Dr.
Hello.
Sejal Naik. I'm from western part of India.
Nice.
Yeah, Dr. Sejal is a joint secretary of our society. It's called Indian Association of Gynae Laparoscopic Surgeons.
Yes.
So she's quite popular and a big organizer for all big events. And there's a Eagle project in India running where she's taking the training to all the medical colleges in the country and making all the uh, teachers and the student in the medical college practice laparoscopy. And I must say, Sejal, it is really picked up in the medical college since this project has started. Yeah.
We have
So
almost done 157 medical colleges and nearly
157.
10,000 PGs are sensitized in endoscopy. So we
Wow.
hope
Yeah,
new new generation will come up with the good laparoscopy skills.
yeah,
That's amazing. I know
yeah.
that there are massive skills in India. I watch a lot of videos of Indian surgeons, so I know that you're very good in surgery.
Good
Hi,
evening.
Amit.
Hello, ma'am. How are you?
Good, good.
Good evening. Good evening, Nutan
Good
ma'am.
evening,
Good
Sejal.
evening, Vidya ma'am.
Adrian, you met
Hi,
Dr.
madam.
Mukherjee? Uh,
Sorry?
Ma'am is ex-chairperson of the UP chapter of IAG. So ma'am is the president of UP chapter. She's the ever president of our chapter because she's one of the pioneers in the country as far as women gynae endoscopic surgery is concerned, and she started way back. So.
In
Uh,
1992.
Wow.
1992, ma'am, started.
Were you born, Adrian, at the time?
I was born, I was 3 years old.
So, another Dr. Sujal Munshi has joined. He's the vice president of Indian Association of Gynae Endoscopy. So he's going to be in the race for the next president. So all the best. So yeah. So Adrian, you are in working in France?
Yes. Yes, very
Oh,
impressed to be presenting in front of all of these people.
yeah.
You've
So
already
we
given your chapter on this topic for us.
Yes, yes, yes. I know
are,
you read my chapter.
So
Yeah.
you are on holiday and still being here for a webinar?
What? Sorry?
Are you on a holiday?
Yes, I'm in my holiday.
uh,
I had a week of holiday and it's Friday, so the end is in 2 days. Yeah, I will be
Adrian, we
working on
visited
Monday.
your center in August 2024. At that time, probably you were not there.
In August, usually I'm in holidays, yes.
Yeah. No,
Okay.
I visited Bordeaux, your Horace Roman Center in 2024.
I thought you said in August 2024. In 2024, I was there actually. Maybe not when you were there, but yeah, I settled in Bordeaux in 2023, in November 2023.
Mhm. That's a,
Okay.
Yeah.
So it's mainly endometriosis surgery center, or it's all
We do
kind of.
only endometriosis surgery in Bordeaux. And the IFEMENDO is the European Institute for Endometriosis Management, and it's settled in Bordeaux in the Clinique Tivoli. And I've developed another center which is mainly endometriosis, but we have some cases of prolapse, ovarian cancer, and like infertility, laparoscopy, and stuff like that. But it's like 75% of our activity there is endometriosis. So
Endometriosis.
95% of my activity is endometriosis.
Okay, okay. So we welcome Dr. Naren Malhotra, sir. Sir is the founder, chairperson of UP chapter of IAG, Indian Association of Gynae Endoscopy, and sir is ex-president of FOXY. FOXY is our national gynec society. Sir, and Adrian is from France, sir, and he is
Hi,
IFEM
Adrian.
Endo.
Hi.
Hello.
So, sir is also into lot of sclerotherapy for ovarian cyst and endometriomas, and he's one of the pioneers in ultrasound guided sclerotherapy for ovarian cyst.
Great.
Yeah, sir has also been doing it since a long, I think maybe sir 20 years.
Yeah, we used to inject ethanol first. Now we have Escarol available in India. Escarol is a small injection which the surgeons use for varicose veins. So
Yeah.
we drain the cyst and inject it. And in endometriomas also, yes, we have quite a few cases. Sometimes it's difficult to drain the complete endometrioma
Yeah.
by so thick needle, but then we keep washing it with saline and antibiotics. And then finally, when it is clear fluid coming out, then inject. So it does work.
Yeah. Yeah, this is why we don't use a lot in transvaginal. In our center, we don't use transvaginal because we're not a center of IVF. We do only laparoscopy,
So it's referral of whole of France, I believe,
Yeah,
about you.
we've heard
There are a
about it.
lot of transvaginal ethanol sclerotherapy in France. There is the team of Marseille, Laura Miquel, that I've
Barcelona, yeah.
published. Yeah.
Okay. Okay. So I think it's 7:05 now. I'll just ask Dr. Sudha Tandon ma'am if she can, join because she was traveling to Delhi. So
Amit, I think she's boarded the flight.
she's boarded the flight.
Yeah.
So then should we start?
Yeah, she's given me the permission. She said, you
Okay.
say, tell this to
Acha, okay, ma'am. Good evening. How are you?
Yeah, good. Thank you. Thank you, Amit.
Very senior.
Yeah. So, okay. So I welcome you all to this UP chapter IAG, which is on conservative surgery for endometriosis and adenomyosis. And I would request Vidya Bhatt ma'am on behalf of Dr. Sudha Tandon ma'am to welcome all the speakers and the chairpersons for this webinar.
Thank you, Amit. Thank you so much. It's been a great opportunity to attend the webinars of IAG because it is always of high standards. And something on endometriosis is always welcome because every day, every person and every nook and corner of India is talking about endometriosis today, and the right management is very important. So Dr. Sudha was supposed to give the introductory speech, but she is boarding a flight. So on behalf of Dr. Sudha and on behalf of entire office bearers and the managing committee of IAG, I welcome you all for this webinar, the renowned speakers and the chairpersons. And my congratulations to Nutan ma'am and Amit for all the hard work put in, getting the international faculty, getting things right. And a hearty welcome, Narendra sir. Great to see you. It's always a pleasure to listen to you. So, a hearty welcome to all of you, and best wishes to all the speakers. And whenever I attend these UP webinars or any webinar of IAGE, I see the standards being so high. And today, I know there is international faculty and our local renowned faculty. So definitely everybody attending this webinar are going to have a lot of take-home messages. So thank you so much for inviting me. Thanks, Amit. Thanks,
So,
Nutan.
yeah. Edwin, Dr. Vidya ma'am is Secretary General of, of Indian Society of Gynae Endoscopy, and ma'am is organizing a big conference, the national conference in Bangalore in March
Yes.
2027. So, ma'am, you can invite Edwin also
Yeah.
to come there.
I take this opportunity to invite you all to the next IAG National Conference, which is going to be held in Bangalore, March 19, 20, and 21st. We look
Yeah,
forward to welcome you all in Bengaluru from
yeah,
KIAG,
yeah,
Karnataka IAG chapter.
Amit was saying that you invite Adrian also.
Yes,
yeah.
definitely.
With great pleasure.
Definitely.
You can
Dr.
send me an
Adrian, you're
invitation.
most welcome. You're most
Thank
welcome
you
to
very
Bangalore.
much. It will be a
Yeah.
pleasure.
And Bangalore is in South India. It is known for its beautiful weather and it is a garden city.
Yeah, I've been there. I've been in Bangalore.
Yeah,
I've been
Okay.
he was Bangalore.
5-6 days. Yeah,
Yeah, then I
it's
think
great.
you should come to Bangalore.
Yes.
I'll be back.
Thank you. Thank you, Amit. Thank you so much for
Thank
this
you, Vidya
opportunity.
ma'am.
For
Thank
being
you so much. I would request Dr. Naren Malhotra sir to say a few words as the opening remarks for our webinar.
A very good evening to all of you. It's indeed a pleasure to be here, seeing IAG being so active, and especially the UP chapter doing wonders in surgical skills and the academics. We have Nutan, who's published a huge book on laparoscopic surgeries. We have Amit, who's doing robotic surgeries in Agra. So it's really wonderful to have all of you. Dr. Neelam Mishra is there, I can see. A great people in our state of Uttar Pradesh. Uttar Pradesh, as you all know, is the fourth largest country by
Okay.
population wise. It's India,
Okay.
China, America, and Uttar Pradesh.
Okay.
So it's
Okay.
India, China, America, and Uttar Pradesh. So, and see how much endometriosis we must be having. It was supposed to be a South Indian disease. Now it is equivalent or maybe more in North India. So it is a very enigmatic disease, difficult to diagnose. It's like what I call in my talks a benign cancer. And
Oh,
it's practically impossible to get rid of this disease with so many of the modern treatments which we have in medical treatment, surgical treatment, ablations, robotic surgeries, everything. And we need to classify it as AMOS or EMOS, adenomyosis or extraovarian or the endometriomas.
that's it.
Whatever you do to these endometriomas are likely to come back. And
Yeah.
that is where a lot of people who are not experienced with endometriotic surgeries are doing a lot of repeat surgeries. 3 times laparoscopy is done, 4 times laparoscopy. I think that is not the right way to treat this disease. We must do a good primary surgery or and medical suppression, and depending on the age, depending on the if the patient needs fertility, if she's going for IVF or if she's perimenopausal, menopausal, depending on that, plan the complete surgery or medical treatment or IVF or whatever. Now, here we have an alternative where we can drain these endometriomas and sclerose the wall, and hopefully they don't occur. I believe the recurrence will be reduced to almost 60%, what I've seen in my clinical. We used to do it laparoscopically. Now we've started doing it transvaginally. And I think we published one paper also using escarole. Escarole is a cheap injection with sclerosing agent, which is available in India, which the surgeons use for varicose veins, inject into. So it's very harmless, can be injected anywhere without any side effects and all. So what we do is the endometrioma, drain it with a thick needle, keep flushing and washing it to get the thick fluid out by saline and antibiotics. Once it is cleared, and then, so what these escarole or ethanol or pure alcohol does it, you have the endometriotic wall and that it causes inflammation. And with the inflammation, they will become adherent. They stick to each other. And when they stick to each other, the cyst is collapsed and adherent and likely not to refill again till you manage the fertility or IVF or whatever. So that is what we do. I'm looking forward to hearing Adrian on what it. So wonderful organization of this webinar, Amit and Nutan. Without wasting any more time, I think we should go ahead and listen to real science what Adrian has to present. Thank you for inviting me here to give the opening
Thank you,
remarks.
sir. Thank you, sir. Nutan ma'am, please, we would like to have some opening remarks from you as well.
Yeah, I will like to be extremely short because we have such excellent faculty with us and we are really waiting to listen to Adrian. And only one observation I want to share with all of you and with Adrian also. Like, I think what I see that the fibrotic part of endometriosis is growing very drastically because we started doing these surgeries way back in 94, 95. And at that time, usually it used to be more of endometriotic cyst only. And the spectrum of DIE, RV nodules, parametrial, even morning what I did was totally encapsulated. So it is my feeling that could it be related to the high-speed internet? Just my feeling that in India we have unregulated high-speed internet. Every homes are having those TV antennas. So, and the girls are keeping their mobile phones in the pockets, which is very close to the pelvis. So what the type of endometriosis I saw in Bordeaux, they were relatively cleaner cases. In India, we get a lot of jammed up, much more fibrotic disease. So maybe if we get time, maybe after his talk. So how does sclerotherapy will be good for all those highly fibrotic cases leads to be seen. So Amit, carry on forward. And we
Yes.
welcome Adrian once again.
Yeah. So our chairpersons for this talk by Dr. Adrian are Naren Malhotra sir, Nutan Jain ma'am, and Dr. Jyoti Mishra and Dr. Sejal Naik. So I will request Dr. Sejal Naik to please introduce Dr. Adrian Cristani. So I will just place your your slide. Dr. Cristani. Just a minute, ma'am. Yeah, here you have. No, yeah. So, Dr. Sejal, are you able to see Dr. Cristani's slide?
Not yet.
Is it
No,
now
no,
visible?
slide share, it was coming, now it is gone back again. So put on slide share and put full
Slide
screen
share.
and then move the slides there. We can see Sejal. Hi.
Hello, sir. Hello. It's
Uh,
always a
slide.
pride and privilege to be here with the IAG team.
So, can you see it now, Sejal?
No,
It's
you have to
coming.
double click to enter the full screen mode. We still can't see it. Niche wo full screen. Yes, now we can see.
Yes, yes.
Make it full screen.
Full screen. Yeah. So now seen, sir?
So, yes.
Yes.
Thank you, Dr. Amit, for and the UP chapter IAG for organizing this amazing, actually the need of an hour webinar on the conservative management, because left and right we are operating and we know the limitations of surgeries, and as Narendra sir rightly said, how many times you can keep on operating a patient. So this is the really a eye-opening webinar today, and we have Dr. Adrian, and I'm so feeling privileged to introduce him in this on this platform. Sir is instructor for IFEMINDO Academy since 2025, and he is one of the pioneers in endoscopy, in especially in endometriosis, as he already has mentioned that 95% of his work is dedicated to endometriosis, and might have seen the variety of presentations, and we must be really going to be very much enlightened with his topic today on sclerosing therapy for endometrioma. Sir has taken training from the various university, from University of Paris, and for the other training in ultrasound, as well as the diploma in oncology also. So the thorough concept of ultrasonography and oncology, as we all know, is very well aptly applied into the disease, especially in endometriosis. Sir is a surgeon in Bordeaux, and minimal invasive surgery, especially for endometriosis, is one of the biggest centers where we look forward for our future trainings in expertise into the endometriosis. Sir is a chief in clinical academy in Paris, Department of Surgical Anatomy, in year 2021 and 23. So we are here with the Dr. Adrian, and we are hoping to have the really very enriching talk today. So stage is yours, Dr. Adrian. Welcome you to India and to this. Glad that we are having this online Zoom platform to have this amazing interaction with the all the experts.
अच्छा जोखिम अच्छा वो किसी और के नाम से रेफर है अच्छा अच्छा अच्छा
Thank you very much for this
Excellent.
nice presentation.
Thank you.
And
You're welcome, sir.
can I share my screen with you right now?
Yeah, we got it.
Okay.
Amit, stop sharing, then he can share.
Yeah, stop,
Yes.
stop sharing. Okay.
So I have a few seconds to thank you for your introduction and organizing all of this. I know it's a lot of work to do, but it went very well on the
Amit,
organization.
mute yourself. तुम्हारी आवाज आ रही है सबको.
I've met a lot of Indian people because we have a lot of fellows that come in our center, and we met a lot of Indian excellent surgeons, and that really know the disease very well. And I'm sure that it would be a very nice congress with a lot of good results. It's a great opportunity. Thank you so much for inviting me today, also, and for inviting me, Dr. Newton, for this chapter. Can I share?
Yeah.
Yes,
Yes,
please.
great. Okay. Okay, now you can see my screen, right?
Yes, can see.
Yes, sir. Yes.
Great. Okay, so as you say, I do surgery most of my time, surgery and consultation on endometriosis, and let's say 30% of my time I do research, clinical research for endometriosis, and one of my main research field is how can we manage endometrioma, and especially in the context of infertility. So this is one of the questions we ask ourselves daily, as you said, daily when we care about gynecology in general, fertility, and of course endometriosis. So this is the picture of an endometrioma. As you see, the only thing that we want to treat is the purple wall of the cyst, and after that it's fibrosis. So I will just quick introduction. I have no conflict of interest. The objective of the introduction is to place you in the context of why we need sclerotherapy, and then we will talk about the technique itself, show a video, and talk about then our data, our publication, and the future. So why do we need ethanol sclerotherapy? Because we have many techniques in this field. So as you know, cystectomy is actually the gold standard in the recommendation, international recommendation, French recommendation, European recommendation for the treatment of endometrioma. But we all know, even if we're the best surgeon, we all know that when you take a cyst out from an ovary, an endometrioma, I'm talking about an endometrioma, you will bring oocytes to the lab with the cyst. There is no histological cleavage plane. In this surgery, you can see that there is what it seems to be a surgical cleavage plane, but it's not an histological cleavage plane. It's just the line between the fibrosis and the normal parenchyma. There is no wall of the cyst. So this is what you will bring to the lab. And here on the red line here, you can see this is an oocyte. And the biggest the endometrioma, the more oocyte you will bring to the lab. And this is why now we have a lot of documentation, a lot of publication that measured the impact of this technique. So if you talk about AMH, anti-Müllerian hormone, the impact is measured above 2.1 nanogram per milliliter. The pregnancy rates in the literature is very heterogeneous. And to date, there are no publication, randomized control trial that showed that one technique is better than another. There is a small randomized control trial about laser CO2. We're going to talk about that later. Recurrence rate is quite good, between 9 to 26%. So this is why we have developed ablative techniques for the treatment of these cysts. There is CO2 laser ablation and plasma ablation. Nowadays, there are two companies that send plasma, two main companies, RB and the Plasma Jet that was published a lot about the technique. The first one I want to talk about is CO2 laser. So, of course, you all know Stefano Ferrari and Massimo Candagno, two very well-known Italian surgeons that have published a lot on this topic. It is a very good technique if you know how to use it. It has a thermal effect. You burn the surface of the inner cyst, so it means that you need to everse the cyst, and then you will burn the surface of the cyst. But size matters. If you have a big cyst, in this study, they show that if the cyst is above 5 centimeters, there is a doubled risk of recurrence. So if your risk is 20%, it will be 40%, which is not tolerable. The pregnancy rates after this technique is quite good, but also heterogeneous. Then plasma. So of course, you all know Horace Roman. Professor Horace Roman has developed the use of plasma in endometriosis surgery for endometriomas, but also for pelvic dissection, resection, etc., etc. It has little to no impact on the ovarian reserve. Frankly, it's a very nice technique to use, quite easy. The thing is that it is quite expensive. The plasma, the device itself is quite expensive. So if you need to use it only for the endometrioma, it will have an impact on the cost for the patient. The second limit is that, as you see in this picture here, you need to reverse completely the cyst so you can treat perfectly the cyst wall. There are not many publications about the techniques and pregnancy rates, but it seems that the techniques brings a lot pretty good results for fertility. The major limit is that if you've used it once the ablative techniques, you know 1 second after you use it what is the major limit. Because imagine this is a A4 page, classic page. This is the surface of an 8 centimeter cyst, 1/3 of this page, and you will need to treat this surface with a less than 1 millimeter laser or plasma, however whatever technique you choose. So imagine the time it will take to spread your energy on all of this surface. It will take time, and of course you're gonna miss let's say 1 millimeter square, and I'm pretty sure more than that. This is why you can have some recurrence. So this is why in big endometriomas we have reached the limit of these ablative techniques, and most of the time the patient were offered cystectomies or simple drainage. I don't talk about the simple drainage because to me it's not a surgical technique. If you do drainage, the risk of recurrence is 100%. 4 studies, four times the same result, 100% recurrence after 6 months. It's okay if the patient will go right after for IVF, but she will recur in 6 months, and after the pregnancy, you will have to do the surgery again and again. So as the chairman introduced my talk, we are aiming to perform less and less surgeries in our patients. 1 surgery in your life is the best. If you have to go for more, it means that there is a problem. So let's talk about laparoscopic ethanol sclerotherapy. And I want to say that I here only talk about laparoscopic ethanol sclerotherapy because we have no experience in terms of transvaginal ethanol sclerotherapy. It's really 2 different techniques, because when I present in congresses, people always tell me, why don't you perform this surgery, this technique transvaginally? And we're not aiming for the same thing. When I do surgery, it is to resect all the endometriosis. When you do a transvaginal sclerotherapy, of course, you just treat the endometrioma. You don't treat the disease outside this endometrioma. So we perform this technique when we also do simultaneous resection of the deep endometriosis. And this has to be very, very clear. So the first team that published about this technique was the Italian team of De Cicco Nardone. So it's the whole family that publishes, and in the Gemelli Hospital, of course, you all know them. They're pioneers of the pioneers, and they published the study of 53 patients in 10 years. There were like big endometriomas. This was the limit we reached, remember, big endometriomas, most of the time they were associated with deep endometriosis also, and severe endometriosis, because we know that when you have a big endometrioma, there is 4 times higher risk to have severe endometriosis with bowel lesion or bladder lesion, and this has been documented in the literature over and over. So they had very nice follow-up, 31 months, which is very, very quite big. The recurrent rates was 9%. 9%. And the definition of recurrence was a 2 centimeter endometrioma on the same ovary. So this was very, very impressive. The pregnancy rates, remember this number, the pregnancy rates was 57% after 2 years. The pregnancy rates in infertile patients was 58%. Again, remember this number, they're very important. So when I arrived in Bordeaux to do my fellowship, it was in 2020, I saw Horace Roman and colleagues performing this technique. I had never heard of it. I had heard of it transvaginally, but I had never seen it laparoscopically. And I thought that it was a very interesting technique, because you treat the whole cyst walls There is no like technical issues. It looks very simple and accessible as long as you have a Foley catheter and like basic skills in laparoscopy. I don't say that it should be put in all hands, but you don't have to be brilliant to perform these techniques. So I wanted to spread the technique all over to my colleagues, gynecologists. And so I published this laparoscopic sclerotherapy in 10 steps. It is available online for free on YouTube. You can find it after this presentation, and I will present the video to show you how we perform the surgery. This is what you need: a Foley catheter, small syringe to inflate the Foley catheter, a big syringe to put the ethanol inside, and then the puncture, another syringe to introduce your ethanol in your big syringe. So it's very, very accessible. The only limit, and I know that this problem is not resolved in all of India, because I was talking to Sandesh Kader a few months ago, is that in some centers we don't have ethanol, and this is not just for India. It is for France. It is for other country also in Europe and in America. Ethanol is not so accessible. I mean, pharmaceutical ethanol. Of course, you can buy a 10-liter pure ethanol in some shops, but it's not made for surgery. So how do we do? I will show you the video. It's, let's say, I cannot. One second. Yes, okay. So here, so please prevent adhesiolysis, because if you do adhesiolysis, you're going to rupture your cyst and you're going to lose the technique. So the first step is to perforate the cyst, and it is quite easy to do. Here you can use any device you want, or you can directly introduce your trocar in case of huge endometrioma. I love this technique because it's really easy to use, and you put your aspiration directly in your trocar in your endometrioma, and you don't have 1 liter of blood inside your cavity. When you cannot see, you have some blood in your cavity. Yeah, so then you rinse. It's classic technique. You rinse, and then you introduce your Foley catheter with the help of your nurse, and so she inflate the balloon here with 3 to 5 milliliter of air, and then you put your ethanol. Make sure that you cannot see it on here, but make sure that you have fluid in your cavity. I always put, let's say, 500 milliliter of fluid in the pelvic cavity, because if you have a leakage, maybe you did a little bit of adhesiolysis of the ovary and there is a perforation of the endometrioma, and you have a leakage that you cannot see, you have to dilute the ethanol. So I always put fluid in the cavity. And the other thing that the Italian team of the Gemelli Hospital taught me is to put blue dye in the ethanol. We don't systematically put blue dye. I do, but you can do however you want. Be careful that blue dye, when put in contact, some blue dyes put in contact with ethanol, do some clots. So you need to use the good blue dye. During the 10 to 15 minutes, you can do whatever you want, and then after 10 minutes, you retrieve your ethanol. So you see here, we measure the perfect volume of ethanol, and then we rinse the pelvic cavity. Some teams take a sample of endometrioma to make sure and to have a proof that it's a proper endometrioma. There is no recommendation for that. when the patient is over 35, 40, I took a sample of the blood that is inside the cyst. And yes, but if you're worried about that it can be a cancer, of course, there is no time for sclerotherapy. It's time for annexectomy or cystectomy, of course. So let's get back to our presentation. Yes. Can you see my screen? Yeah, I think you can do. So, so now what about our data and what did we publish on the topic? So right after I arrived, after my fellowship, we published the impact on ovarian reserve of the use of ethanol sclerotherapy. Because in our opinion, really you need to measure this impact before saying that it's a very good technique and everyone can use it, because no one knows and no one knew at the time what ethanol was doing to the surrounding ovarian parenchyma. We made the experience of drinking, you know, what impacts it has on yourself. Of course, it's chronic ethanol, but yeah, having this ethanol in your blood, we didn't know what impact it had on ovarian reserve. So this is what we wanted to measure. We had 69 patients in this study. We will see the population after. The impact was measured at 1.3 nanogram per milliliter. So there is an impact of deep endometriosis resection plus sclerotherapy. This impact is major is bigger when you have a higher preoperative IMH. So this is why you need to inform your patient that if she has a big endometrioma and a big high anti-Müllerian hormone, the impact will be important. The second analysis was for fertility outcome and recurrences, and we published this paper in May 2025 in the IGJO. So it's the same cohort of patients. It's a prospectively gathered data for our 134 patients. The median follow-up is 23 months. So let's have a look on the population. It's quite, let's say, for patients that have a desire for pregnancy, remember that these are all patients with deep endometriosis and they want to have a baby after the surgery, or at least fertility is an issue when we think about the case. So they are quite old patients, for patients that want to have a baby, 32-year-old, and 1/3 of the population has experienced infertility. It means that they had previous ART care for most of them. And most of the patients, 85%, are nullipayers. So this is what our patients have become more and more in France. Patients are older and older for the first baby, and they need more and more ART techniques. Preoperative IMH was around 3. So let's see the technique. So you can see here that the size of the endometrioma was very big, 7 centimeter mean size of these endometrioma, and all of the patients had deep endometriosis resection, but almost 1 out of 2 patients had a bowel procedure during this surgery. Most of them was segmental bowel resection. The EFI score was not that good. The mean was 5.4, and that's not very good for the pregnancy after that. So let's talk about this fertility outcomes. So we had 134 patients. Right after the surgery, only 78 of them wanted to have a baby right in the 2 years after the surgery. 45 of them became pregnant, so that's 57%, exactly the same rate than the Italian team. And 58% of this pregnancy were through assisted reproductive technology. Of course, because when the patient has a big endometrioma, is older and has undergone a big endometriosis surgery, she will go faster to IVF than spontaneous pregnancy. The time to obtain the pregnancy was a little bit more than a year, and there was no difference between spontaneous or through ART.
Sorry
This
to
graphic-
interrupt you, sir. We are unable to see your slides.
Oh, since when?
Just
Last
recently, sir.
4 or
We
5
have
slides.
seen.
Since the video stopped, it's still paused on that video.
Oh,
That screen.
it's still on the video?
Yes.
That's bad. Because I can see. I will try to do it again. You should have interrupted me for. Can you see it now?
Yeah.
Yes, sir.
Okay. Sorry for that. You can interrupt me anytime. So this is the thing that you would needed to see. These are the two papers we published. With the first one was in SMIG and the second one was in IGGO. This is the population, the table of the population in the second publication, as I was telling you after. And this is the last picture I was talking about with the 134 patients. So this graphic is very important. This is the cumulative pregnancy rate through time. And it's very important to inform our patient. After 30 months, if your patient is not pregnant, it means that the probability to get pregnant after that is very low. So you have to inform the patient that she has to go straight on after the surgery. The best, as you know, in the publication, the best is during the 2 years after the surgery, but still there is an effect after 2 years. But after 3 years, no, 30 months, it's going to be complicated. So now let's talk about these patients that were infertile, because this is very interesting. In patients that had ART before the surgery, 57 of them got pregnant, the same rate of patients of the general population. Of course, most of them through ART, because they are in failure of 2 IVF procedure before the surgery, or they wanted to have IVF immediately after the surgery. But it is also a very important message, a take-home message to bring, is that it's not because they will go through IVF that the probability to get pregnant is lower than the general population. And this is why our patient want to have information that our patient want to have. Let's see now the multivariable analysis on the probability to get pregnant after the surgery. So of course, we know that, and you said it before, more and more surgery means less and less babies. And there is no discussion about that. Maybe because they underwent a surgery on the ovaries before you, with the cystectomy, with the plasma, anything. And maybe because they destroyed the anatomy, or they impacted the anatomy through previous surgery. And preoperative anti-Müllerian hormonal level is a good is a predictor for postoperative pregnancy. Means that if your preoperative hormone is very low, the probability to get pregnant is lower too. And this is known by all the IVF specialists. I have nothing to say here. Live birth rate. Is there an impact of ethanol on the pregnancy after the surgery? And this is a question that the patient asks all the time. If I get pregnant, does your procedure impact the way my ovary works during the pregnancy? These numbers, of course, there is no control group in our studies. So there is no way I can say that sclerotherapy is better or worse. But these numbers are quite usual numbers after pregnancy. So as I was telling you, 45%, 45 patients got pregnant. And we had 9 pregnancy losses. Most of the time there were 9% pregnancy losses. Most of the time there were early miscarriage. So that's 91% live births. Recurrences. Recurrence, as you said in the introduction, is very important, because when you have a recurrence, and if the recurrence is painful, and if the IVF specialist needs to go to retrieve the oocytes, he will ask you to treat again the endometrioma. And you know that if you treat once, twice, 3 times an ovary, at the end there will be no more ovary in around the cyst. So the less recurrence, the best it is for our patient, of course. So out of the 134 patients that were introduced in this study, in this follow-up, 103 had an imaging during the follow-up. Because of course we don't always do imaging during the follow-up for a patient. If the patient is asymptomatic, she doesn't have to go perform any ultrasound or MRI every year. We had 16% recurrence, and the recurrence definition is a 2 centimeter cyst that looks like an endometrioma on the same ovary. That's quite a harsh definition for the clinician, because of course when you have a 15 centimeter cyst on the left ovary, if you come back 6 months after with your ultrasound, of course there will be something on the ovary, and this something can be a 3-4 centimeter cyst with thick blood inside, but we don't know if this is an active endometrioma or this is just the rests of the endometrioma that you treated before. We don't know that, and there is no other definition than that can be accepted in this type of surgeries. We had only 2 redo surgery for the endometrioma. So 1 patient recurred on the bowel lesion, and at the time, because she had before 10 centimeter cyst, and at the time of recurrence she had 4 or 5 centimeter, I don't remember, 5 centimeter I think, cyst on the same ovary. We did plasma on the rest of the cyst walls. In case of recurrence, if the recurrence is smaller than 6 centimeter, we use only plasma. If the recurrence is higher than 6 centimeter, we use ethanol sclerotherapy, but there is no data. There is no solid data on this use, this repetitive use of ethanol sclerotherapy. Let's see how these recurrences looked. So we had 4 recurrences that were above 40 millimeter. Then we had 4 recurrences that were below 4 centimeter, between 3 to 4 centimeter, and most of the recurrences, the majority of the recurrences, were small endometriomas. I think we can easily say that these are the scar tissue of the endometrioma, but still it has to be measured. When we looked at AMH, the impact on this cohort was 1.1 nanogram per milliliter. And one question that I always get is, do you have immediate post-operative complication related to the use of ethanol, like dizziness of the patient and stuff like that? We do not have that. The team, there is another French team that uses a lot of ethanol sclerotherapy, and they are going to be in our study, longitudinal study and randomized control trial. And they measure ethanol. They measured, because they stopped last year. They measured ethanol after the surgery 1 hour, 3 hours, 6 hours after. And they, of course, some of the patients had ethanol in the blood. The worst case was 1 gram per liter ethanol in the blood, which is something that you get if you drink a lot of alcohol, of course. But the patient didn't have any like specific symptoms, because of course when a patient wakes up from a 3-hour surgery, she will be dizzy, she will be she won't feel great. So it's impossible to make the difference between ethanol toxicity and just propofol and other drugs. The other thing that we had, actually I had two, is when you use produces like potato starch after the surgery, you know, hyaluronic acid. So I had 2 cases of patients that had an abscess of the endometrioma, because I don't know if because of that, it's only 2 cases, but I used potato starch, you know, the powder to prevent adhesions after the surgery. And those 2 patients had an abscess of the cyst I treated by ethanol. I never get this usually, but it happened twice, and twice it was ethanol sclerotherapy plus anti-adhesions product. Future now. So is it possible to create a randomized control trial to have the final answer about sclerotherapy compared to cystectomy? It's quite difficult to answer that. Oh, something happened. Can you see my screen?
No.
Yeah, I think someone.
No, it is
Something went bad. Yeah, it stopped. I will share again.
Yeah, please.
Okay, can you see it again?
Not yet. Yes, we can.
Great. Sorry. I don't know when it stopped, but yeah. So it's impossible to create a randomized control trial at our scale in Bordeaux, because we would need 375 patients per group. So it would mean, I did the calculation, it was 21 years to perform the study. So I would be quite old, and we don't have time for that. We need an answer. So the answer would be an international randomized control trial, but it takes a lot of energy to do that, and we need numbers. We need good numbers to predict the time we need to perform this study. So this is what we are performing actually in Bordeaux. Oh, it's not working. Yeah. So now I'm the primary investigator of this study called ATOP. It is ablative techniques for ovarian preservation in endometrioma. We started the inclusion in October 2025. So the idea is quite simple. If you have an endometrioma above 2 centimeters, and you have a desire of pregnancy after the surgery, and you have deep endometriosis, so 3 conditions, either you would go to IVF or spontaneous pregnancy, we don't care. We randomize the treatment for your endometrioma. If your cyst is below 6 centimeters, so between 2 and 6, we do either cystectomy or plasma. If your cyst is above 6 centimeters, we treat everyone with sclerotherapy. So this is a prospective cohort. We want to do this prospective cohort for the next 2 or 3 years. So we measure exactly the rate of pregnancy. So then we can calibrate and calculate the exact number of patients we would need. Because in here, I did this calculation with a 10% difference between cystectomy and ethanol sclerotherapy. But this was like in my mind, you know, it's not really good statistics. So maybe we will be able to calibrate a next randomized control trial, international randomized control trial in the next 2 or 3 years. And it's time to finish now. I have a few take-home messages which are quite important today. Ethanol sclerotherapy is a safe technique. We know that. The risk of toxicity of ethanol is very low. It has been used and used and used in different specialties. It has a low impact, but still it has an impact. You cannot tell the patient that it has no impact on the ovarian reserve. It has good results on fertility outcomes. We cannot compare because we need a randomized control trial for that, but it has good fertility outcomes. It is very accessible, low tech and easy to perform. But as I was telling you, we need more data. And we will not have this answer in the next, I would say 10 years, we won't have this answer. And of course, the patient selection is mandatory. We can talk about that later. At the Femando, just to have a quick mind, as I was telling you, if you have deep endometriosis, endometrioma, and if fertility is an issue, and if your cyst is above 6 centimeters, this is time for laparoscopic internal sclerotherapy and deep endometriosis resection. If your cyst is below 2 to 6 centimeters, plasma or cystectomy. This is how we do actually. Thank you very much. You can find me on the social media, mainly Instagram and LinkedIn. And if you want to have very nice
all look forward to. So I think Dr. Xiaoming Gong requires no introduction, I think, anywhere now. He's a pioneer in ablation techniques. Actually, he is a pioneer in all the techniques, I would say, but more so in ablation techniques. And he is an expert in all kinds of ablation techniques, whether it is HIFU, whether it is microwave, whether it is radio frequency, and has an extensive experience. I know him personally as a friend, and he's also my guide, and he's someone who inspired me to take up ablation and bring microwave and RF ablation for especially adenomyosis in India. And has recently been installed as the president of International Society of Obstetric and Gynecologic Ablation, ISOGA. We just had our first international congress in Philippines, where he was installed as our first president. And I think he has a long list of achievements. We'll have to take an entire session for that. But I'll give it to you, Dr. Xiaoming. You can take it further, your talk.
Xiaoming, Dr. Xiaoming.
Coming, you're on. You can.
Hello, I'm back. Hello.
Yeah.
You can
Yes,
Yeah, we can hear
Xiaoming.
you.
Hi. I just thought. So I already sent a recorded lecture. So probably
Yeah.
you can play that lecture first, and then I'll go back to answer any questions regarding my talk.
Okay, we'll play our lecture. Lecture play. So till we start the lecture, we know Xiaoming is an excellent hysteroscopic surgeon. I saw a big type 2 submucous fibroid which you were removing, and still you are interested in doing, minimally invasive management.
I also do school therapy, but mainly, ultrasound guys.
Yeah, ultrasound guided. So that is in those cases where you don't want to treat the other part of the DIE, only the endometrioma where you want to treat. So, but is there any chances of infection? Higher chances of infection?
Actually, for vaginal approach, mainly we do vaginal approach. Everybody think about it, that's a high chance of high infection rate. But if we do screw therapy, the infection rate is low. But if it's just a puncture and you don't do screw therapy, the infection rate is a little higher. So we always, when you put the ethanol inside, we we actually, for so many years, we never see one case of infection. That's our experience coming from. There's also a lot of the study in China we did for the scleral therapy compared to the cystectomy. And there's some of the research data regarding for this. There's a very good result. So actually, we use this scleral therapy to take over the laparoscopic excision to less and less laparoscopic surgery anymore.
Okay, so should we play a talk now?
Sure. Go ahead.
Okay, we'll start with the. Are we getting the screen?
No, sir. The screen is there, but now it is there. It is
Yeah.
visible. It has not played, I think. You will have to play. Huh. We are not able to hear anything.
There.
Yeah, the audio is not there.
Audio is not there?
No, we
No.
cannot hear.
We cannot hear.
Okay. Okay. Audio is not there.
नहीं उसमें ऑडियो में जा रहा हूँ ऑडियो में जा रहा हूँ स्टॉप शेयरिंग
Just a minute. We'll take a couple of seconds.
चला गया है
Share sound.
अब वो वीडियो प्ले करनी है ना पहले वीडियो प्ले करनी है पहले हाँ ये ठीक है
Hello?
हाँ हाँ
If you cannot use that video, maybe I just go through my slides.
Now can you hear the voice?
No.
Voice is being heard? No.
Amit,
No.
it's not audible.
Ma'am, can you hear?
No, we cannot.
No, we cannot.
Cannot. Okay. Okay. I think, Xiaoming, if you can play your slides.
We can.
You will have to
Doctor,
stop sharing.
Yeah, stop share.
Yeah, you will have to stop sharing.
Okay. I will try to open my file so we can talk. So can you see my slides?
Yeah.
Yeah.
Yes.
Yeah, we can see. Yeah.
Okay. So thank you for the invitation. I'm very glad that to be with this IAG. I want to go to India for many times for the IAG meeting, and last year I'm not able to get my visa. So hopefully that I will go to IAG meeting next year in India next year, and hopefully we can have a microwave workshop together with Dr. Sriyash and with our SOGA International Society of Gynecological and Obstetrical Ablation Society. So ablation is a new thing. It's actually compared to the traditional surgery, we use our laparoscopic surgery or hysteroscopic surgery to do resection. But now, when we go to the ablation therapy, we use energy to destroy the tissue. So now we have several energies. We have HIFU, we have microwave, we have radiofrequency. So we use all these kind of things. We call it ablation. And in China, we also use another word, which is called a super micro invasive surgery compared to the traditional minimal invasive surgery. So this is a new generation of surgery. I think that's the future. As I told you that now I do less and less laparoscopic surgery because of ablation. Ablation take over many of the laparoscopic surgery, and also those sclerotherapy and be part of the choice for those cystic lesion in the ovary. So traditional surgery, either to do hysterectomy or to do the resection treatment, we use laparoscopic or open surgery. It's the traditional things. Ablation therapy uses energy. So if the temperature rise to 65 degrees, the tissue will be degenerated in 1 second. In China, right now, ablation therapy is widely used in many stroma tumor, like the liver cancer, kidney cancer, lung cancer, thyroid cancer. In uterine disease, I think that we use it for about 20 years, starting from my journey with ablation therapy, starting with from HIFU. HIFU is high intensive focused ultrasound. I started this HIFU in year 2009, and then later on we have the MR guided focused ultrasound, which is a very expensive machine. Now I think that in many of the world of the places, MR guided focused ultrasound is mainly done by the radiologist. But microwave and the radiofrequency, we started in year 2016 and 2017. In the recent 2 to 3 years, I think that it's becoming very popular in India. More and more doctors is start to use the microwave and the radiofrequency in this new area of the treatment. Compared to the traditional resection therapy, ablation therapy has many advantages, like it has a fast recovery, minimal pain, no wound or no blood loss. But it also has some disadvantages. If we don't do biopsy, we don't have pathology. And also has a higher residual tumor and higher infection rate and reintervention rate. So this is it has some good thing and also disadvantages. But for us, we think we have many reasons to choose to do ablation therapy, because for our uterine fibers and the adenomyosis, it's mainly a benign disease and it's a hormone related. It will relieve after menopause. So we don't like the lung cancer. You have to remove it. So I think that for our gynecologists, ablation therapy is a good choice. So we change from laparoscopic surgery or open surgery gradually to move to the ablation therapy. And also one reason is that we know that the chance of malignancy transformation is very little, especially for adenomyosis. For myoma, with the something exists is a sarcoma, but with MI, now we can rule out those kind of malignancy before the treatment. So this is a very important concept. I know that in many countries, MI is very expensive, and also it's not easily accessible to many patients. However, I think that if you want to do the ablation therapy for fibers, you have to do the evaluation with MI, because this MI is very important to do the differential diagnosis between the myoma and the sarcoma. I will show you some of the cases that is not suitable for I won't do ablation therapy. This is in the MI signal, the T2 signal, which is a high signal, which means that it's a more water inside. In this cases, if you do with energy treatment, the energy reaction not good. So we, in the beginning, in the early years, we don't do this kind of the cases with HIFU because the HIFU energy is relatively low compared to microwave. In the recent years, for those kind of T2 high signal tissue, we will prefer to use a gene analog to do the treatment, and after a few months, then we can start to do with the ablation therapy. For the case 3, those kind of patient with fertility denial, if you do ablation therapy, the energy will probably will injure the endometrium as well. So in this case, we prefer to do those kind of the hysteroscopic resection instead of using energy therapy. Also, we need to watch out those sarcomas. This is the case we operated several years ago because a patient came for mammectomy and accidentally she had MI. We checked her MI and saw this is DWS signal is very high and also the ADC value is very low. So this is a very good sign for sarcoma. We didn't agree to do mammectomy for her. It turned to be a low-grade sarcoma. So this is the one thing as I said, that is one thing you can tell which one is a sarcoma, which is a benign myoma. So MI evaluation is very important. Also, for some of the myoma, we always do biopsy for myoma case. For adenomyosis case, we don't do biopsy because it's not so useful. But for myoma, we always do either the transabdominal biopsy or do transvaginal biopsy. So we get a piece of the tissue to get the pathology diagnosis. HIFU is I don't know if it's available in India, but HIFU is my journey for the ablation therapy. So this is the Chongqing HIFU, which is also is a very expensive machine. We used it in the year 2009 when I was in Peking Union Medical College Hospital, and we started to do HIFU at the time. This is how it works. This is this energy device. This is a transducer, so it can produce the energy and it can penetrate the abdominal wall, the skin, and the uterine wall, reach the uterine lesion. So after those kind of the ablation HIFU, so you can ablate and it causes the volume reduction after the treatment, and also you can improve the symptom after the treatment. This is also a comparative study, control study in my country, over 2,400 cases. Compared with the surgery, you can see HIFU treatment, it has less adverse events compared to the traditional surgery. And the hospitalization day and the recovery day are less compared to the traditional surgery. This is our study for the adenomyosis. So you can see after the treatment, the pain relieved in a few months, and this is the VS score. In 3 months, it decreased by 3.7. In 6 months, it decreased by 4.7. However, we still need to know that with this traditional conservative management, the reintervention rate after 10 years, this is after 8 years, the reintervention rate is reached to 50%. So this is our data regarding for the adenomyosis. The reintervention rate is very high. So this is just an image to show what is the ablation. After ablation, you can see some those dark area. We call it a non-perfusion volume. This volume is gradually shrinked after the ablation, so it gradually decrease in size. The second technique is actually MR guided focus ultrasound. It's the same principle with the focus ultrasound, but it was under the MR machine. With the MR machine, this image is clear. So with this MR monitoring, we can see the transducer produce the energy, goes through into the body, and then ablate the myoma or adenomyosis piece by piece, and gradually we can achieve a very high. This is computerized the ablation, the treatment plan. So we can, from this coronal view, we can see those ablation energy is penetrate the skin. It's a column. It's a small bar that can reach the body. What we should do is in the computer we circle the treatment zone, and the machine can produce energy to the myoma. This is one of the treatment bar we saw in the one procedure. As we can see, this is a temperature. So one thing of the MRI machine monitoring is that it can has a temperature monitoring, which is good for those fertile patient. So you can see where the energy goes. Once the temperature goes to reach to 65 degree, and then we can see this green bar mark the tissue, and we can see how the energy goes. So this is also a very safe procedure, especially for those patients with. However, this is a long procedure, like a 10 centimeter of the myoma. We probably need about 4 to 3 hours to do the treatment. Also, we get a similar result from the MR focused ultrasound, similar to HIFU. After treatment, the patient's symptom get improved. And in year 2015, FDA approved its use in the pregnancy woman. So after ablation, we can see the similar adverse result with the normal group. And the third technique is called the microwave. Microwave right now is the main ablation method we use for ablation. Now about 80% of my cases are done with the microwave. Microwave, it works just as the microwave oven in your kitchen. So it can produce the energy. So this is an antenna. This is the energy device. It can produce energy at the tip of the antenna. You can see this. When I put this antenna inside the meat, it can produce the energy. With accumulative time, you can see the tip is becoming very hot, and the tissue is burned over here. So with the accumulation of the time, this zone is ablated. However, in the antenna itself, it has a cold water inside. It bring down the temperature inside, so it won't cause the damage to the normal tissue. So when we put the antenna inside, either through the percutaneous or through the abdominal wall, or we can reach from the transvaginal approach, or we can go through the uterine cavity. Sometimes we also do a lot of the ablation for the adenomyosis with laparoscopic surveillance. So this is some of the approach we can do with a microwave ablation. Also, we have our endometrial ablation, which is also a very traditional treatment for the patient with the amenorrhagia. This is energy produced. When you put the energy inside, we can see that the energy causes the necrosis of the tissue. However, the surrounding tissue is normal. So the traditional treatment for ablation is guided by the abdominal ultrasound. The abdominal ultrasound can guide your inserting of the antenna. The antenna, when it's reached into the position, we can ablate the mama little by little, piece by piece. For our ablation, our principle is that want to keep the safety. So we don't want to achieve 100%. We want to keep the energy inside the capsule of the mama or inside the uterus. We don't want to ablate too much of the normal tissue or even burn the ball. That's the dangerous thing. So that's our thing. It's different with the cancer treatment. When we do the thyroid cancer or the lung cancer, you have to ablate the cancer and also the surrounding tissue. Indication is similar to our surgery for fibers. It's usually we choose to do those symptomatic fibers. And for those fertility desire patients, we usually treat those type 5 to type 3 to type 5, greater size of than 5 centimeter. So this category of the patient is a very beneficial from this kind of the treatment, because in the past, usually we will have to do a laparoscopic surgery. Patient will need to wait about 6 to 10, 12 months to be get pregnant.
We lost connection.
We lost connection, probably.
Anthony, what was that? I think we just lost connection. कैसे confirm करें?
WhatsApp message you can drop a WhatsApp, but I'm not sure.
Yeah.
इसका डिस्कनेक्ट हो गया
हाँ?
ये डिस्कनेक्ट हो गया
अच्छा
सुना नहीं रहा
अच्छा
सुना नहीं रहा
You can call him
हाँ.
and find out.
Dr. Suyash, if you can.
I've just messaged him
Yeah.
that
Yes.
he's got disconnected.
You have been disconnected.
I think he's online. He will read it.
Yeah, you can.
Back to
Let's start. Let's start this. What are you moving on? So
Okay.
can you try to play my video again?
Okay. Let me see if I can open. So his computer is stuck and he's not. So I'm trying to play his video. Yeah.
It's interesting actually. In the meantime, any one of us has any experience of ablative techniques? Okay. Yeah.
Oh, voice
हाँ सर मैं सर यहाँ से कर रहा हूँ
Some error with the computer system.
सर अभी शेयर हो जाए
Amit sir, hello.
Yeah, yeah, wait,
On my YouTube channel, I have his lecture. If at all this audio doesn't work, I can
yeah,
play from there.
yeah. Uh, are you able to hear the? Are you able to hear the talk?
No.
No. So I think you can play the talk.
Recording
from your-
stopped.
Uh, uh, Dr. Amit, you have logged in from two devices, so I think echo is happening. You will have to switch off the mic of one device.
That's the mic switch.
Or Dr. Suyash, you can give commentary on the video which is running.
I
That is
think
another.
Dr. Gong has just entered again, joined
Okay.
again.
Great.
Let's see if he's able to share. I have his video on my YouTube channel also. If needed, I can share and play that.
Sorry,
His lecture is
my
there.
computer gets stuck. Can you play my video?
Not yet, Gong. We cannot see your screen.
So maybe I tried again because my computer is getting stuck. So it's um, maybe I use a small screen. It will be better. Hope so. Can you see my slide?
Not yet. No, we cannot see.
I think I'm sharing now.
Still not visible.
We cannot see, Xiaoming.
Oh, hold on.
Can you
I'm
stop
trying to.
stop the presentation, PowerPoint, and restart it again?
Yeah. I'm trying.
Yeah. Close the program and restart it again, and then you share.
Yeah. Mm. My computer is getting very slow. That's why I'm sending a video first.
Now we can see your screen.
Okay. So you can see my screen.
Yes.
Mm. So I was starting from the microwave ablation for the indication. Contraindication is just similar to many of the our laparoscopic surgery. So one thing is very unique that is type 7 myeloma. When you have this pedunculated myeloma, it's very difficult to fix it, and sometimes it's very easy to move. So with ablation therapy, this kind of ablation is not suitable for those type 7. And also some of the cases when we have a patient have very poor image, especially like a patient with abdominal scar or obesity, then percutaneous ablation is not a good choice. If you do vaginal approach, and you also need to check the image before you do the ablation, because usually, you know, when you have a very big myeloma or big adenomyosis, and it's a very difficult to check the image with a vaginal approach. So usually we will do the patient, we put the patient in a lasarotomy position, and we sit on the patient's right side. This is a circulation system. It can bring down the temperature with the cold water. We also will do artificial ascites with put a normal saline in the abdominal cavity with this pump. This is sorry, I cannot play this video. Maybe later on. My computer getting stuck. This video is the way we do the percutaneous ablation. This is a contrast image before the ablation. So excuse me, can you see my slide?
Yeah, we can see your slide. We can see the ultrasound film, and but it's moving very slow.
Slide. We can see the ultrasound film, and but it's moving very slow. Yeah, I think that's because the file is very big. It's like a 2 gigabytes. So you know, it's why maybe the transmission of the internet is very good. It's not good. No.
So should I play a video and you give the commentary? Or Suesh, can you play
Can you
this
try to
video?
play my video again? So that
Yeah.
makes better. I think that there's a voice.
I'll try to play a video.
YouTube?
And then
Yeah,
you
there's
film.
one video I talked with.
And if required, you can talk on it verbally.
Because
Charming, if Dr. Amit
transmission
can
is
play your
very
video,
very slow.
you can speak.
So that's you try to play my. So I stopped my sharing. I stopped my sharing. So you try to play the video I sent to you. Did you download it?
Yeah, I have it. So I'll play it. The voice was not coming. You can speak on it along with the video. Yeah, okay, correct.
Okay. Let me turn on my cell phone. So my computer is getting stuck. It's very slow.
Screen on.
Oh. Those speakers.
Sir, you need to move the video ahead where microwave ablation is starting because
Yeah,
half the presentation is over.
yeah, we'll do that. Just a minute, loading it. So typically till the time he starts, what sizes is the most optimal for, uh, ablation by microwave? Yeah, you do a lot of myoma ablation as well, with the microwave needle.
Yeah,
Yeah. So what
uh,
is the sizes you normally do?
the size.
Yeah.
Uh,
Uh,
usually, usually, usually I would treat the myoma less than 10 centimeter. If the myoma is greater than 10 centimeter, I will use the gene analog to shrink a little bit and then to
okay.
do the ablation.
So
So
I think,
try. Can you try? Can you try to play my lecture again?
yeah.
So maybe I can
Done.
add my voice on if you cannot see
Yeah.
me.
तो कैसे चल नहीं रहा?
सर आवाज आई तो
नहीं प्ले नहीं हो रहा है। हाँ ये चला
और
ये फॉरवर्ड कैसे होगा? हाँ
नीचे है just next to the stop symbol there is a speeding symbol.
this
Yes, yes.
ओके नहीं कुछ चला गया या और आगे करना और आगे और आगे
Yes, I think this is the right point.
यहाँ से प्ले कर लो
This was
Yeah.
Starting from here. Yeah.
Yeah, you can speak now.
Yeah, this is a procedure that we do the ablation. So we put the antenna inside, and we gradually ablate the this is myoma. So it has this patient had a 3 myoma. We ablate one by one. Usually we treat the myoma from the deep position first, and then we move to the superficial one. We judge the energy from those high echo area. So after the ablation, we do contrast the sonography. We can see those dark area is the ablated zone. So we can tell from this dark area if the ablation is enough. Usually we do the MI for patient. As in China, MI is relatively cheap. So usually we put the MI, we do the MI within 1 week. So this is another case for adenomyosis case. This is also the percutaneous ablation. We do ablation, put the antenna inside, insert directly with the ultrasound guide. So this procedure, I know many of you in India are not confident with this procedure because many of you are still doing the laparoscopic guide. But as I said, this procedure is most minimal invasive compared to laparoscopic guide. So I think this is the future. So you need to know about this procedure with the purely ultrasound guide, either percutaneous or vaginal approach. With the percutaneous ablation, you need to use uh, the the ultrasound probe to catch up your antenna. So this is some of the thing you need to practice. In the beginning, it's not easy, but once you learn how to do this ablation, you need to not to catch up the antenna, then it's easy for you to do this kind of the procedure. It's very minimal. We call it super minimum invasive. This is a contrast ultrasound after ablation. So you can see after ablation, this dark area is called, we call this a non-perfusion volume. This is the MI after ablation. We can see this dark area is a ablated zone. It's very clear with MI. This is a diffuse adenomyosis. If we do a percutaneous or transvaginal approach, we have to leave some space around those capsule, along this serosa, because we don't want to ablate too much to the surrounding tissue. So we have to keep the energy inside the uterus. This is after percutaneous ablation. You can see after 3 months, you can hardly see this small incision on her abdominal wall.
So, with percutaneous, there's no risk of uh, bowel dithermy or
Operation.
something. Yeah, injury, bowel injury.
Uh, yeah, this is always for me. I never have a bowel injury for so many years. The only bowel injury I entered is with my laparoscopic approach. I will talk about later on. This after ablation, you can see this dark area. We call it a non-perfusion volume. Will be getting smaller and smaller. So usually after 6 months, the size will decrease by 68 to 80%. So you can see this dark area is becoming smaller and smaller. Uh, this is a case we followed this case for 7 years. So you can see from the beginning to the 7 years later, and the myoma is getting smaller. Same thing happened with adenomyosis. We have many study regarding its safety in China. So after ablation, you can see the efficiency usually after 6 months is decreased about 50 to 80%. Uh, this is one of my case. We do ablation for some cystic the adenomyosis. So in traditional treatment, we use a laparoscopic procedure. It takes about like 1 hour to do this resection and repair. For this case, we did ablation for 5 minutes and then done. Patient have no pain after the treatment. And also we can see this dark area. We ablate those lesions very well. So patient has no pain after this VS score turns from 10 to 0 after the treatment.
Yeah.
We have our own data regarding for the adenomyosis for the ultrasound guide ablation. So no pain in 46% of my cases. About 10% of my cases not satisfied. So finally did a hysterectomy. So in generally speaking, that this if the treatment is effective for those patients, either for the pain or for the heavy bleeding. The second procedure we can do transcervical. We call through the uterine cavity. So we can put the antenna inside, guided with abdominal ultrasound. Uh, your assistant have to catch up with your antenna when you move your antenna. So this is procedure is also it's easy, but you have to collaborate with your assistant. Uh,
Your voice is not there. Voice gone.
the voice on. So
Now we can hear you.
yeah, the third message is we to do with the vaginal approach. So we put the antenna through the guide. So the guide will restrict your movement of the antenna. So you put the antenna inside. This approach is actually very easy to learn because the guide will always let you to find the antenna easily, and it's very clear. The image is very clear, especially for lesion was in the posterior wall or close to the cervix. This approach is very easy and easy to learn. The only thing you need to have a guide, a vaginal ultrasound guide, and also a long antenna, 25 to 30 centimeter of the antenna. So you can put the antenna inside, and then you can get it through the vaginal, and then reach the lesion. This, I think that if you feel that percutaneous approach is difficult to learn, this approach you should learn it first. I think it's easy to learn and also very very clear image with the vaginal ultrasound. Mm.
Yeah, so we've lost your voice.
No, I'm not
Hello.
speaking.
You're not
Yeah.
speaking.
I'm just waiting for the next slide.
Okay. Okay. So does the fluid find a route to escape from the cavity or into the abdomen, or it get absorbed?
Pardon?
When we
Sorry, I cannot. Sorry,
the
I cannot
degenerative.
hear you well.
Okay, now are you able to hear me? Are you able to hear me now?
Yeah. Can you repeat? Can you repeat?
So where does the fluid drain? In the abdominal cavity or in the uterine cavity? Like the fibroid you have ablated has become cystic
No.
kind of
Actually,
fibroid.
Actually, it's not always to be cystic degeneration. It's sometimes it just turns to be necrosis and then gradually absorbed by the blood. Sometimes you if you ablate, this is the approach we do laparoscopically. We do laparoscopically mainly for those adenomyosis. So compared to the vaginal, the ultrasound guide, the laparoscopic ablation can achieve a higher ablation rate. So that's why we do the laparoscopic ablation only for those patients with adenomyosis without fertility desire. That's the difference. I know Suyash started to do laparoscopic approach because you feel not confident with your ultrasound approach, ultrasound guide approach. But I do the laparoscopic approach mainly because I want to achieve a higher ablation rate, so patient can have a better result with the pain relief and the menorrhagia relief. So in next slide, we can see our data regarding for the laparoscopic approach. So I may answer your question. After ablation, those dark area will be absorbed by the blood supply. So if you use degeneration. So from our study, you can see 82% of cases has had no pain after laparoscopic approach. So that's our experience learned from this laparoscopic approach compared to the ultrasound guide. Only 3.9% of the cases had a hysterectomy afterward. So I can see this approach for adenomyosis is a effective and safe procedure. Sometimes we also put the ablation together with the hysteroscopy. So we resect this type 2 to type 0 to type 2 myeloma, and also we ablate those type 3 to type 7 myeloma with ablation because we don't want to use laparoscopic approach. method because it's painful for the patient. However, the hysteroscopic surgery is still a choice for our patient. For those patients with a fertility desire, we will put those hysteroscopy exam before and after ablation. We resect this type 0 to type 2 submucous myeloma with the hysteroscopy. For patient with a fertility desire, we'll keep the ablation zone away from the endometrium, away from the serosa. So usually we'll leave 5 to 10 millimeter away from the normal endometrium and the serosa. This is our method to do the ultrasound guided ablation. For diffuse one, it's more difficult to do. If patient don't want to get pregnant, so we can ablate the endometrium as well. This is one of the procedure we do combined procedure with a hysteroscope. So we inject the gel and the medicine bamboo underneath the endometrium to protect the endometrium. So this is one of the methods we developed to help to protect the endometrium. In our past, when we do the HIFU, sometimes the energy will hit the endometrium, will cause the endometrial damage, and also cause the endometrial adhesion, and will cause the infertility tissue problem. So this is antenna, and also we put a Foley catheter inside the uterine cavity, and irrigate the cavity with the normal saline. This is a very interesting case. This is also our very first beginning of the ablation for fertility desire patient with adenomyosis. Patient has 20 weeks of the miscarriage and the IVF failure, and she had an open surgery, and after that she had a recurrence in her waiting time. So in this image we can see she had a 7 centimeter of the adenomyosis recurrence. So she don't want to do another open surgery. We did ablation. After that, we can see the dark area, and after that we give her gene for 4 months, and finally she had a IVF successful. So this is a very first case for us to do with a fertility desire patient with adenomyosis. Patient has infertility problem, and has recurrent IVF failure, and has 21 weeks of miscarriage. For our experience, at least this ablation is not is comparatively with open surgery. So after that we had a study. We just have our data that our data show that the ablation rate for the live birth rate for pregnancy woman is about 58%. So this is very good result for those infertility patient is very hard to get pregnant. So this is our some of work with those patients was infertility issue. This is endometrial ablation. This is also another the technique we can apply it with the same machine. Endometrial ablation is only for those patients without fertility desire. So we only treat the patient with symptom with heavy bleeding. After bleaching, we can see anemia relieved in 100%. The patient's symptom is getting relieved. However, the infection rate is about 13%, which is higher than our traditional resection therapy. So this is one of the things I want to mention about our endometrial ablation with microwave. Next one. Maybe I'll just wait. Uh, Lastly, I just want to mention because we have very limited cases, we publish data for our 4 cases of the cesarean scar and endometriosis. So compared to the traditional resection therapy, this is a very simple procedure. We just put the antenna inside and guide it with ultrasound. we can ablate the cesarean scar and endometriosis very easy. So this is a simple procedure. You just need to watch out the ablation energy damage to the skin. So you need to put some like the gel or fluid to protect the skin. For complications, I don't want to mention about too much because it's not a lecture about all these technique, but it has some risk. Compare just as you mentioned that if you have any complication with the bowel injury or uterine rupture, this will maybe happen. It's just like a laparoscopic surgery. If you don't do it correctly, you may have some complication like the bowel injury. I have only one bowel injury with laparoscopic approach. The only one happened with my laparoscopic approach. So I just want to let you know, not always that's the same. That laparoscopic approach must be a safe procedure. Ultrasound guide is not. So that's my talk. Let's finish. Thank you.
Thank you, Dr. Xiaoming Gong, for a very wonderful talk. And it just opened our eyes how beautifully you were doing microwave ablation. And it was really super microinvasive surgery. And as you said, it is the future of the microinvasive surgery. And you very comprehensively told about in detail the advantages, who are not suitable candidates, what are the contraindications, and then percutaneous route and transvaginal route, and how you combine with hysteroscopy. It was really wonderful. I want to know only one thing. What is the learning
Thank
curve
you.
for this? Learning curve.
Learning curve.
Learning curve.
I yeah. I think that if you know ultrasound, then
Yeah.
it's easy.
Okay.
If you don't know ultrasound, then you have to learn ultrasound first.
Yeah,
You know,
yeah. It's
in my
ultrasound
country,
guided.
many gynecologists, yeah, many gynecologists in China, we don't do ultrasound by ourselves. So that's one of the issues. That's I started with HIFU. So in the beginning, I learned ultrasound by HIFU little by little. So I gradually know how to do the ultrasound guided procedure. And also you need a very good ultrasound machine. Otherwise, it's your eye. You cannot just like a laparoscopic surgery. If you have like a 4K of this the endoscopic system, it's a very good system. And if you have very old machines, then you cannot do your procedure very good. So I think that this is one of the things. If you know ultrasound, you just know how to put the antenna inside and how to monitor it, how to know where is the antenna, how to do ablation is very simple. You just follow up those procedure. So I think that if you know how to do the ultrasound, then you in about 1 to 2 months you can learn how to do it. If you don't know ultrasound, then you have to learn ultrasound all from the beginning. So that takes a long time.
Okay. Okay. Thank you. Thank you very much.
And I have one question.
You're welcome.
Yeah.
Yeah.
If we were to do a laparoscopy later on the myoma or the adenomyoma, which was already treated by Mia, so what are the changes and how is it
Yeah.
difficult to nucleate the myoma?
Uh, it's just, sometimes I will tell you that I would do those big myeloma, like a type 2 myeloma. It's unresectable with a histology in the beginning. So I will ablate it first and then wait for a few months later. And then I do with shaver and a hysteroscope. It became very soft. It's very easy to remove with a shaver. So if you do laparoscopically, you can see usually you have a capsule, and inside the capsule is very soft. It's just like tofu. In China we have tofu. It's very soft, and you take it out with a spoon. It's very easy to take out.
So is it difficult to dissect those my such like we give mifepristone and all, and that after that it becomes soft. So in those cases also, this happens. So resection may be difficult.
Uh, yes, if you compare to the traditional, you use your modulator. Yes, it is. But you can use other instrument, like you can use suction, you can use a spoon. I don't know if you have this kind of a spoon that can take this tissue out easily. So as just told you that when I do those patient without with a big myeloma type 2, we use we use ablation and also the opium method. We cut the endometrium and let the myeloma will push into the uterine cavity. And in the second step, you can remove this myeloma with shaver. Shaver, like those soft tissue. So it's I think that it's easier for the experienced
True
endoscopy
clearance stores.
surgeon. It's easy. It's not a big deal.
Dr. Gong,
And if
yes. Any experience with obstetric complications in patients who have undergone this therapy and conceived afterwards?
Good question.
can you repeat your question again?
Patients who have conceived after microwave ablation and they have undergone obstetric, any complications that you have encountered during pregnancy or at the time of delivery?
Any rupture?
Okay. Okay. I got you. I got you. I said I have to say that uterine rupture, for me, my case, I have some cases of uterine rupture reported after HIFU, after microwave. So the important thing is you need to watch out the ablation zone. You don't want to ablate too much. You don't want to ablate normal myometrium, normal endometrium. So this is the one of the thing you need to watch out. I do HIFU in the past, but HIFU has its disadvantage because you cannot see where the energy goes. So that's why I use MR guide HIFU for those patients with fertility design because you know where the energy goes. When the temperature reached to 65 degree, with the microwave, because the energy is very high, we can tell from the high echo area. We can see where it goes. So you can see tell where's the ball to tell where it, just remember, don't abrade too much. Just like to do a
Yeah, but in your series,
laparoscopic mammectomy, you need to suture.
okay,
In my series, no using rupture.
okay, great.
Okay. No uterine rupture in your series. Okay. So, any experience on endometrial
Sorry.
ablation?
Sir, how much time do you allow the patient to get pregnant after HIFU? How many months? 3 months or?
Uh, 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 usually,
I think signal is quite low. I
I
think
think we
in India,
lost him again.
Yes.
yeah. Our Indian colleagues, they start doing it, I think, the next month. They start rendering the patient for IVF or whatever. The very next month, they do the endometrial ablation. Shuez, what is your
I don't.
experience?
You mean to say for fertility? To start fertility treatment? I
Yeah,
don't think it's a good idea to start next month.
okay.
I
At
think
least 3 months.
in my practice, I start after 3 months, if at all. Uh, because we are doing it to reduce the disease burden and to reduce the size, right? For example, in adenomyosis, sometimes it is compressing the endometrium and the shape of the endometrial cavity becomes S shape. Okay.
Yeah,
So your transfer becomes difficult. So unless the disease bulk goes down, okay, you will not have that advantage. And 2 months will not give you any significant edge on starting fertility treatment earlier. For me, I wait at least for 3 months.
3 months. Okay.
I don't know about what is the idea of Xiaoming, what he does for fertility, but I wait for 3 months, and that has worked out well.
Any
But
experience on
for
endometrial ablation? Does
I
it
don't
work?
do endometrial. I have not done endometrial ablations, frankly speaking, sir. I have, because of Mirena, I have never felt the need to do endometrial ablation because once the Mirena fails, the patient generally resort to something more
Hello.
more definitive.
Okay.
Charming
Okay.
is back.
Yeah.
Charming, the question for
Sorry,
you was,
my cell phone. Uh,
are you there?
yeah, I'm back.
Yeah. So the question for you was, after ablation, when will you start
How many months?
the fertility treatment in after how many months or after how many days?
You mean get pregnant, right?
Yeah, to get pregnant, when will you ask patient that she's allowed to get pregnant after ablation?
Yeah. I think one thing, just a personal experience. Usually I will ask the patient get pregnant 1 month later. So if natural pregnancy, 1 month later. If patient want to do IVF, I will just wait a bit longer. So maybe about 3 months. Just a personal experience, no study.
And I have one question for you, Shami. Where is it? Yeah. Are you there?
Some network issue.
Shoming,
Shami?
can you hear? Can you hear us?
Hello?
Shoming?
Hello?
Yeah, can you hear us?
Hello? Can you hear me?
Yeah.
Yeah, we
Yeah,
can
yeah,
hear
now I
you.
can.
Okay. So did you
I have
hear
one
my
question
voice?
for you.
I said that for
So, Dr. Suesh had one more
hello.
question for you. Yeah, I
Uh,
think
you, you demonstrated that you do a hysteroscopy guided injection of saline and methylene blue below the myoma to increase the distance between myoma and endometrial cavity to, for the safety
Mm.
of ablation, right? So when you are doing this
Yeah.
hysteroscopy guided injection, are you also doing transabdominal ultrasound to see where you are injecting? Or is it only hysteroscopy guided
Yeah.
injection?
I have one slide missing in my the recorded lecture. Actually, after injection, you can see in your ultrasound there's some dark zone between your endometrium and your myoma or adenomyosis lesion. So that's just want to check because I will see usually I will do it's mainly ultrasound guide. It's not a laparoscopic guide. So ultrasound can guide your dark gel and normal saline inside. So we learn this technique actually from this thyroid cancer treatment. They have the nerve to protect, so you have to use the normal saline to isolate the nerve.
Yeah. They inject saline to move away from nerve.
Hello?
yeah, we can hear you.
Hello?
Yeah, we heard you. We heard you.
Yeah, any patient landed in complete amenorrhea? Any of your patients? I think again he's disconnected. So I think there's some problem with the connectivity.
I think we need to.
So I think we can. Are you? There's some problem with the connectivity, Joey?
Now it's getting better.
It's better. Okay. So any of your patients landed in amenorrhea?
No. I actually, unless I do this patient with endometrial ablation, so we will ablate
How are the
the whole
results
endometrium.
how is the results with endometrial ablation? How are the results in endometrial
I think
ablation?
that's yeah. I think that I have a slide in my lecture. In my cases with endometrial ablation, about 100% of the cases had the blood this menorrhagia relief, and the patient have a very good result with endometrial ablation. It's bad. Actually, we do NovoSure as well. So we compare this method with NovoSure. The microwave ablation is actually the amenorrhea rate is higher than NovoSure because the ablation rate is deeper. However, the infection rate is also higher than compared to the NovoSure.
I think the only risk with ablation is infection compared to your
Yeah.
routine
Well,
surgery.
especially for endometrial ablation, yes, it is.
So I think can we summarize the talk and request the chairperson to thank Joming and we can summarize the talk.
Thank you, Dr. Amit, Dr. and whole UP team for, on behalf of IAG, for organizing this wonderful event. It was very great discussion. So we are very happy that UP chapter is very actively doing this. Thank you very much, Amit Bhai, Neelam Madam, Dr. Neelam Ori Madam also, and Dr. Suyash also. Thank you. And thank you, Dr. Ziomi, for joining us and sharing in detail your experience with a very wonderful technology. Thank you.
Thank you, chairpersons.
Thank you, Dr. Amit, for
Thank you,
organizing such a
everyone.
wonderful webinar. I really
Yeah.
enjoyed it.
Yeah. Thank you, ma'am. Thank you, Swash. Thank you so
Thank
much.
Thank
And
you.
thank
Bye.
you, Sujal, for coming and gracing it. Thank you so much.
Thank you.
Okay.
Okay, and thank you, Dr. Joming. Hope we'll connect on phone. Okay.
Okay. Bye-bye.
Thank you. Bye-bye.
Bye. Thank you. Good night.
Good night.